So thank you so much for joining this event on the Lancet Commission on investing in health. The report was published last year by the Commission, and it's called Global Health 2050, The Path to Halving Premature Death by Mid-Century. And that is exactly what we're going to talk about today. What the report says, what the recommendations are, and most importantly, perhaps, how we can make use of them and to put them into practical use and implement the recommendations to actually achieve substantial reductions in premature mortality and in morbidity and so on. So we will have enough time to discuss all these issues later. But first of all, I would just like to introduce myself. My name is Malin Arne. I work at EBA, who is hosting this webinar today. So EBA is an agency that evaluates Swedish aid. It's under an agency under the Ministry for Foreign Affairs, and it's short for the Expert Group on Aid Studies. So we commission evaluations, and we also organize seminars and webinars like the one today that we're having today, and produce a podcast on topics that are relevant for Swedish aid. And last year, EBA published a report on global health and health aid, and it was an anthology. I have it here for those of you who haven't seen it. And one chapter in the anthology was on the Lancet Commission on investing in health. So therefore, we are very happy to organize this event today and to be able to disseminate the findings from the Commission to a wider audience, and especially in Sweden. And my background is in public health, so I'm very happy to be moderating this event today. And the program is pretty straightforward. We will have a few presentations from our guests that are with us today. And then following that, we will have time for questions from the participants. And you are welcome to post your questions at any time in the Q&A function at the bottom. And we will also record the presentations so that we can share it with others afterwards. We have 3 speakers with us today, and I'm very happy to welcome Angela Chang, Justina Seyi-Olajide, and Jesper Sundewall. Unfortunately, our 4th speaker, Gavin Yamey, was not able to join us today due to unforeseen events, but Angela will also cover Gavin's presentation, so thank you for that. And I think I'm gonna start by introducing Angela to give us the first presentation. So Angela is an associate professor at the Department of Public Health at the Danish Center for Health Economics. She's also a member of the Lancet Commission on investing in health. And she has also recently received a Danida grant on a study in Uganda to study climate youth migration in Uganda. That's not something that she will talk about today, but it was just worth mentioning. So Angela, you're our first speaker, so I would like to hand over to you to share your presentation, and I'll give the floor to you. So thank you so much.
Great. Thank you, Malin. And thank you everyone for joining. I hope you can see my screen here.
Yes, yes.
Great. And And thank you for the introduction. And I also wanted to say, so I live in Copenhagen, and I was recently part of the expert group on global health in Denmark, where we're also doing something similar to what the EBA is doing, but less official, I would say, in that we had a group of experts in global health trying to come up with some recommendations to the Danish government on their ODA policy. And it was a very interesting and also challenging task to make. So later, I'm curious to hear from Jesper about what's happening in Sweden and also from the participants as well, and what Denmark and Sweden can learn from one another. So I will be talking about the key messages that come out of the Lancet Commission on Investing in Health, our report that Malin just mentioned. And then I'll also talk a bit about the financing of it. And I'll provide you with a brief background, because I know that not everyone on this call is working in health, and not even within health, you may not have heard of this commission before. So I'll provide a brief background. This commission has a long history, in that there are many, maybe stepping back, there are many Lancet commissions. So for some of you who know the Lancet is one of the biggest medical journals with long history. It's a British medical journal. And they have many commissions, Lancet commissions. But the editor, Richard Horton, claims that the Lancet Commission on Investing in Health, our commission, is the commission of all commissions. And the reason is because it has a very long history. It's dating back to 1993. And so for people who are in the global health field, you may know that there was a World Development Report published by the World Bank in 1993 called Investing in Health. This was the first time the World Bank's annual report focused on health. That time, the chief economist of the World Bank was Larry Summers, who later on became Treasury Secretary under Clinton, and then later as a senior advisor to Obama, and then the president of Harvard, and so on and so forth. And so he has many titles. And he was the chief economist at that time. He commissioned one of his star employees, Dean Jameson, to write this report together. And this was 1993. And this report was quite crucial in many ways in changing the way we think about health. One is that these two are economists. So Larry Summers and Dean Jameson are two economists who think very differently from how epidemiologists and medical doctors think about health. They talked a lot about evidence-based interventions that are cost-effective. They talked about investing in health not as an expenditure, but as an investment for countries to make. And this, for some of you, you may also know the idea of the disability-adjusted life years, DALYs, which is a measure that combines mortality and morbidity. That measure also came out of this report. So many big things happened with this report. One of, I think, contribution of this report to in real life, in actual terms, is that one of the readers who read the report said that this report was mind-blowing. Now, I don't know about you, if you ever read these kind of reports, whether you would ever say that these reports were mind-blowing. I read many of these reports, and I would never find myself saying that these are mind-blowing. They're like nice, they're well written, or they're like, oh, very informative. I would never say these reports are mind-blowing, but one person did. And this person was none other than Bill Gates. So Bill Gates at that time, Microsoft, he was still at Microsoft, and he was thinking about how to think about his philanthropy kind of legacy and what he wants to do. He read this report and thought it was mind-blowing that, despite the fact that rotavirus vaccines existed, that lots of children were dying from diarrheal diseases. And so he was quite impacted by this report, and he credits this report as one of the key reasons why his philanthropy, the Gates Foundation, ended up spending a lot of their resources on global health. So that was 1993. 20 years later, so this is 2013, the Lancet editor, Richard Horton, asked Dean Jameson and Larry Summers to revisit the messages that they wrote 20 years ago, sort of as an anniversary, and think about what's next. What does global health look like from these experts? And so the Lancet commissioned this report with these two chairs. So Dean and Larry wrote this report. And if some of you may know, there are big names in global health who wrote this report, and was also quite influential. This was 2013. Now, 2013 was a time when the Millennium Development Goals were still happening. SDGs was just coming up. This previous report influenced how the SDG goals were set and discussed. And then 10 years have passed since. So this 2023, the world has changed dramatically since 1993 and since 2013. We just had the COVID pandemic. The funding for development assistance for health has sort of stagnated. The golden ages of what people called, the global health golden ages have sort of slowed down. The MDGs were gone. SDGs the world was not on track for many of the SDGs. And so the Lancet editor, Richard Horton, again came back to the two chairs and asked, well, so what? Like, now what? Now what do we do? Like, how do you think about how the field of global health should go? And what are the directions that you foresee? And remember that this was 2023 that they asked that Richard asked the chairs to write this report. And this was before all the US cuts and things have happened, right? So think about this is 2023, 2024 when we wrote the report. And so I'm going to talk about this report that was published in last year, October, and it's been a couple of months since we've published. And I'll talk about the 7 key messages, and you're welcome to read the full report as well. And I'll also highlight some of the things that I think are relevant more than ever, I think, especially now in the context of aid being cut here and there, including in Sweden. So before I start about the report, I'll just say that this report, we call it the GH 2050, so Global Health 2050, is a high-level report led by 2 economists. Again, so they're quite different in terms of the way economists think than how other people in health think. It is a product of discussions and debates among 50 commissioners that we have across different genders, different geographies, and different generations. So for example, Tina and I are new members of this Lancet Commission. We were not part of 1993. I don't even know what I was doing in 1993. I was not part of 2013, and I'm a new member of the Commission this time. And this report is about all countries. It's not just about low middle income countries or about high income countries. It's about all countries. And of course, this is not a prescription that we're trying to say that countries should do this, do that. That's not the intention. And given the kind of the magnitude of this kind of report at a high level, we don't talk about everything that everyone wants us to say or everything that everyone thinks is important, right? So we have selectively chosen what we say and what we don't say. And that's sort of our kind of internal priority setting, that what we think is more important than not. And if it's by no means perfect. So since our launch in 2024, we've received lots of feedback, both positive, constructive, negative, and we're very open to discussing and learning from one another, because that's the only way these kind of reports are useful. And so I will start with the broader context in which this commission places ourselves. And it's the fact that the world is facing many headwinds. So Dean Jameson, our chair, said he often feels like this dog, where it's like lots of things like throwing in your face at you, and you can't really walk. There's rising geopolitical tension, there's climate change, population aging, decrease in fertility, and few of these headwinds have immediate responses and interventions that are available for us and to tackle. And in comparison, we have better grasp on the issues in global health. We have the knowledge, the expertise, and a good track record on improving population health, as I will show you. And so our general message is doubling down on past health investments, focusing resources on a narrow priority set of conditions. Scaling up financing and developing new technologies can continue to pay off despite these strong headwinds that are coming. And that's sort of our overall message that we give. So we have 7 key messages. The first message is that by 2050, countries that choose to do so could reduce the probability of premature death, which is the probability of dying before age 70, by 50% from the level in 2019 before the pandemic. We call this goal 50 by 50. So 50% reduction in mortality, premature mortality by 2050. This graph shows the probability of premature death over time by world regions. In 2019, which is on the far right of the graph, the probability of premature death for the world, which is the black line, was 31%. And so it means that there was a 31% chance that a person before age 70 would die. And it ranges from the highest in sub-Saharan Africa of 52% to 15% in the North Atlantic. The North Atlantic is a group that we made up, which is basically Western Europe and Canada. And it's the best performing region in 2019. And what we're saying is that if 50 by 50, this goal is achieved, then globally by 2050, the world will be at the same level as the North Atlantic in 2019. So right now we're at 31%. By 2050, if we have it, it will be about 15%, which is where the North Atlantic is right now. And we think that our analysis show that 50 by 50 is feasible based on historical experience and continued scientific advances. Since 1970, 37 countries have had their probability of premature death in the same time period or less, including 7 of the largest, 30 most populous countries with different income and different mortality levels. So that includes, Japan, South Korea, Bangladesh, Vietnam, and so on and so forth. So it's a wide range of different countries. Furthermore, we are quite optimistic because there are more candidate medicines, vaccines, and diagnostics for global health conditions in the R&D pipeline than ever before. Our research suggests that we'll have around 450 new products before 2050. Our second message is that sharp reductions in mortality and morbidity can be achieved by focusing on 15 priority conditions. We in global health, and maybe it's development aid in general as well, as with most human beings and like dogs here, have a tendency to get distracted by the next new shiny thing. Our message is to stay focused, don't get distracted. Our analysis show that of the 17,000 or so unique diagnostic codes in the ICD-11, so that's how we code diseases in the medical system, only a tiny fraction of the 17,000 or so account for the largest proportion of the life expectancy gap between the best performing region and others. And we call these the 15 priority conditions, which we list on the right here, including 8 infection, maternal neonatal conditions, and 7 NCDs, non-communicable diseases and injuries. This figure shows the gap in life expectancy between the North Atlantic, which again is Western Europe, Canada, the best performing region, against all other regions, the life expectancy gap. For example, on the top bar is Sub-Saharan Africa. So the life expectancy gap in 2019 between Sub-Saharan Africa and North Atlantic is 22 years, of which a large chunk is due to these 8 infectious maternal conditions in green, and then a smaller chunk, but still substantial chunk, due to NCDs and injuries of these 7. Right? And basically close to 80% of this gap in life expectancy is due to these 15 priority conditions. And it's not just Sub-Saharan Africa. If you look at all the other regions, most regions, 70 to 80% of the gap can be explained by these 15. And so our message is therefore for countries to stay focused on these 15 priority conditions. In countries that have a high probability of premature death, infectious and maternal neonatal conditions remain the highest priority. But in all countries, including countries still with the infectious and maternal neonatal burden, the NCDs and injuries are important in all countries, and addressing them is key in achieving 50 by 50. Before I go to the third message, I just wanted to also highlight this importance of focusing. So if you think about the background, and as many of you know, globally, everywhere in the world, there's an aging trend because of low fertility, because of the success in increasing survival over time in the population, we are postponing the deaths to a later age since the 70s, 80s, and now these deaths are coming back, sort of, of course, because at some point we all die, human beings all die. And so what we're showing here is the crude death rate. So this is just number of deaths over the population size and trends over time. What we observed is that in 2019, according to the UN, 2019 was the point for the world in which we had the lowest crude death rate. And from that onwards, we're just going to go up unless something drastic happens, but we're just going to go up because, older people die. Right? We're increasing lifespan, which is great, but ultimately people die. And it happens at a different trend in different places. In sub-Saharan Africa, we will not see the lowest point until 2048, roughly. But in most other places, including China, for example, with very rapid population aging, the burden on health systems will be very heavy. And in the case of different financial crises, including cuts in foreign aid, what does that mean in financing and health and health systems around the world? One is back to the earlier message about focus. So if you stay focused and try to prioritize, prioritization is never easy, but prioritization may be and trying to be more efficient may be the only ways to go through the challenging times that we have right now. Our third message is that the universal health coverage and health system strengthening agendas need a reset, and that we propose a modular approach to priority setting. And Justina is going to talk much more about this a bit later. But just to say that we find, so in the World Health Organization monitoring of universal health coverage have recognized that the progress towards UHC, universal health coverage, has not been as well as we would have hoped. And so our commission calls for a reset in thinking about priority setting. We recommend that governments maintain their focus of public financing of a core set of interventions, mostly tied to the priority conditions that we mentioned, that are fully prepaid and available to everyone, starting with the highest value for money. An initial tight focus on these priority conditions can then later be expanded towards a more comprehensive universal health coverage over time. So I will skip a bit here just so that I know Justina is going to talk much more about it. And we talk about how do we finance this modular approach, and we made some estimates in our report that says something along the lines of it will cost an additional 1% of the GDP in low-income countries, and an additional 2% of GDP in lower middle-income countries to scale up the set of interventions that we focus on these 15 priority conditions. And another kind of background for us to think about is that much of the health expenditure is expenditures. And so here we see that drugs, important, kind of essential drugs, especially even for those that are focusing on these 15 priority conditions, are not yet available and affordable for everyone. Irrespective of income levels, as you see here, private health expenditure remains an overwhelming source for drugs in many countries. And in light of available evidence, when drug costs are borne privately, access to priority interventions is then sharply constrained, and plus many households will experience financial distress. So in this light of this background, our fourth message is about publicly financing of drugs. So countries should publicly finance a short list of key medicines for the 15 priority conditions. Inadequate access to essential medicines and high out-of-pocket costs, as you saw, are major threats to our goal of 50 by 50. And we've learned from the Global Fund's experience in doing something similar that we describe in the report. We call this approach the Arrow mechanism, named after the late Kenneth Arrow, who was a Nobel Prize-winning economist and a commissioner of our first Lancet Commission on Investing in Health report, and who developed this mechanism for malaria drugs for the Global Fund in the early 2000s. The Arrow mechanism involves 4 key components, which are to redirect general budget transfers to ministries of health, to line item budget transfers for specific priority drugs, centralized pooling, purchasing, quality assurance, and long-term commitment to manufacturers, procurement in large volumes to ensure availability and use and strengthen existing public and private supply chains. And this Arrow mechanism is, since our publication, this has been one that many country governments have expressed interest in. So can they identify, couple, maybe less than a handful of key drugs that are leading to high out-of-pocket payments at the same time with high prevalence, but they're very cost effective. Can they do something to highly subsidize it so that at the user level, it will be easily available and accessible? Our fifth key message is that the tobacco is the new tobacco. It's now common to hear that other risk factors are the new tobacco. So for example, sugar is the new tobacco, or sitting is the new smoking, and so on and so forth. You've heard many of that. And we argue that tobacco is still the new tobacco. Smoking remains the biggest avoidable cause of death in many populations worldwide. And last year, there was a report by the Task Force on Fiscal Health Policy that Larry Summers was also chairing. And they wrote, raising taxes on tobacco can do more to reduce premature mortality than any other single policy. Our sixth message is that there is a high risk of another pandemic of COVID-like magnitude. We estimated that there were 23 million excess deaths during the COVID pandemic. And one of our background papers estimated this table, which says that in the next decade, there is a 23% chance that another COVID-like magnitude, so about 25 million deaths, will happen in the next decade. So 23%. So it's quite high. And to put it another way, for most years, there will be 0 pandemic deaths. And for some years, like COVID, there will be millions of deaths. On average, if you calculate this 23%, on average, there will be about 2.5 million deaths per year in the next decade. And to put this number in context, it is about the same as the number of deaths currently occurring annually from AIDS, TB, and malaria combined. And this number is much higher than the number of annual climate change deaths projected from even very pessimistic scenarios in the coming decades. All countries, we all know, all nations really need to be ready, but many are not, as you can imagine. There was a huge variation across countries in their performance during COVID, and especially before when the COVID vaccine became available, suggesting that there are lots of lessons to be learned from successful countries about public health basics. So thinking about when we don't have vaccines, what are the non-pharmaceutical interventions that we can do? So the first 6 messages were for all countries. And the 7th and the final key message, this one, is for the development assistance community. We say that development assistance for health is critical in supporting 50 by 50, and it should focus on 2 broad perspectives. The first is the provision of direct financial and technical support to countries with the least resources. And the second is the financing of global public goods, such as the ones listed on the right, and successes such as the malaria vaccines and the more effective tuberculosis vaccines exemplify this enormous contribution of development assistance for health that comes from Sweden, that comes from Denmark and other places in improving the R&D pipeline for global public goods. And for both of these purposes, the direct country support for the least developed countries and global public goods, we maintain the focus on the 15 priority conditions. So that is it for me. Thank you, and I look forward to the discussion.
Wow, Angela. Thank you so much. I think it was super interesting. I couldn't see any questions right now, but please post questions in the chat and in the Q&A function, and we'll come back to that. While I introduce our next guest speaker, Justina. Justina is a pediatric surgeon at Lagos University Teaching Hospital of Lagos, Nigeria. I know you are joining us today from Montreal in Canada. So good morning to you. And Justina is also part of the Lancet Commission on investing in health, and you will give us your perspectives on this. So the floor is yours. So
thank you very much.
Over to you.
Yeah, thank you for the introductions. I'll just share my screen.
Yes.
Can you hear me?
Perfect.
Presentation.
Yes.
Thank you. Thank you very much.
Looks very fine.
Thank you. Thank you, Angela, for that very interesting first segment. I really thoroughly enjoyed listening to it every time. Thank you. Good day, everyone, once again, and many thanks for the opportunity to be here. I'll be continuing this conversation by giving an overview of the modular health system strengthening approach and the modular cost effectiveness analysis approach. The report, as we have been told, proposes that countries should focus investment on 15 priority conditions that have been chosen based on their impact on life expectancy gaps and gains in countries across all income levels. And Angela has talked extensively about this, and I'm just putting this up again just as a reminder to all of us so we can see the conditions once again. So why is the modular approach to health system strengthening important, and why was it recommended? As previously mentioned, the universal health coverage agenda has not been driving progress as expected. And this is because the goal of UHC the vision has been overly broad. The goal was that every health need should be fully addressed for everybody by 2030, and you'll agree that is quite broad. And there has been a general lack of realism about what UHC actually entails in terms of the coordinated efforts and the level of commitment and fiscal choices that need to be made and that's required, like who's going to pay, how much is needed, and what sacrifices are needed to be made for this UHC agenda to actually be realized. And again, the health system strengthening discourse has focused generally on increasing resources in resource-poor countries rather than on how to use those limited resources to directly improve population health and build resilient systems. So for all of these reasons, there has been a call for a reset in UHC and health system strengthening agendas in order to ensure that this goal of 50 by 50 can actually be achieved. So what the Commission proposes is that instead of trying to do everything at once, a step-by-step modular strategy that prioritizes the most important health interventions first and then gradually expands coverage should be adopted. And the Commission has recommended that national government should focus on public financing of a core set of interventions that are fully prepaid through public financing and made available to everybody. However, starting with the highest value for money interventions. So the aim of this is to start with cost-effective life-saving interventions that provide the highest benefit per dollar spent, and then gradually expand coverage. This would ensure that the poorer and more vulnerable populations benefit first, instead of prioritizing expensive treatments and only a few can afford. And also, it also recommends including social programs that help people afford and access care. The big idea ultimately will be that countries are strategically investing in high-impact services first, and this will ensure that the foundation of the health system is very strong. Over time, coverage can then be expanded to include more services and more people, and this will help to move towards UHC in a very sustainable way. So what was subsequently done by the Commission? The Commission identified core interventions for major health conditions that are cost-effective and feasible to implement across countries of all income levels and group them into 19 modules. And these 19 modules address the 15 priority conditions. In addition to addressing the 15 priority conditions, the interventions also address other major health demands on health systems that are usually neglected, like rehabilitation, child and adolescent development, and palliative care. What the modular approach does is that it groups these health interventions into modules, or you can call it program areas, based on their specific policies and financing needs. And this makes it easier to plan, implement, and expand health services systematically. So there are 19 intervention modules that have been developed by the Commission, and these are based on recommendations that were drawn from World Health Organization and disease control priorities. We should look at these modules as building blocks for strengthening the healthcare system and see that they provide a structured way to organize healthcare interventions. So we have these modules on infectious and maternal health conditions, such as immunization, childhood illnesses, pregnancy and childbirth, tuberculosis, HIV and AIDS, cardiovascular and respiratory care, mental health, basic cancer, enhanced cancer care, and a host of other intervention modules. It is important that these modules are a guide, not a set of strict rules. So every country is expected to adapt these modules based on their local needs and their health priorities. This will allow flexibility. So as a country, you decide which module is important for me to implement, targeting the priority conditions that are relevant in my own setting. And we saw what Angela had shared earlier on about the conditions that are making the greatest impact in terms of life expectancy gaps and gains across different countries and different regions of the world. Even though not every module applies to every country, but a significant proportion of these modules will be valuable and necessary for most of the countries. And this would help to accelerate progress towards the 50 by 50 goal. How then will countries decide which interventions to prioritize? Like we all know, many countries have health benefit packages, and these are supposed to guarantee access to specific healthcare services at little or no cost. However, most of these health benefit packages are not implementable because they are either sitting as advocacy documents rather than functional policies, or the cost of the implementation far exceeds available resources. And again, what has been seen is a poor linkage between the health benefits packages, funding, and service delivery. So in order to make these health benefits packages more practical and implementable, the modular cost-effectiveness approach to priority setting has been suggested by the Commission. It is both a technocratic and a political process, and it adapts to local policy processes, health systems, configurations, and financing arrangements, and ultimately to help make health benefits packages easier to implement. What does it involve? Essentially, there are two stages when using this approach. In the first stage, basically modules are defined, relevant modules are defined, and budgetary levels are also defined. And these modules, like we mentioned earlier, should be tailored according to the country's health needs, infrastructure, or financial capacity. And then costs for each modules are estimated with a plan to either expand or reduce funding for each of these modules based on the resources that are available. And then the budgets are allocated depending on what the country's health strategies are. Ultimately, there is also room for estimating incremental costs for the core interventions. So the cost for the coverages can be estimated for expanding the coverage by an additional 10% of the population can also be estimated. And this can give a realistic target for expansion within a particular policy cycle. The aim is that policymakers should have a clear information on cost distribution across the different modules that are being targeted. Now, the second stage of the modular cost effectiveness analysis approach helps to optimize intervention mix within the modules. So once the general direction and the budget allocations for the health modules have been established by planners and politicians, in the second stage, the cost effectiveness analysis actually begins. And what happens here is that the experts that are assigned to each of the modules will identify candidate interventions, map them to their relevant modules, and then carry out a cost effectiveness analysis for each of these interventions, so that within each module, there is maximization of value for money within each of these modules. It's not a one-way process, because sometimes the technical analysis may reveal that some interventions are more impactful or cost-effective than initially thought, and it may not influence the budgetary allocation to a particular module. So there's an opportunity to go back to the first stage, modify the budgeting and estimates that have been done, and then come back to the second stage. So I want to just give an example of how this can be applied to surgery. I'm a surgeon, right? So it's like easier for me to do. But then what is the role of surgery, first of all, in modular health system strengthening? It is important to bear in mind that surgery is an intervention, and one can see that surgery is important in diagnosis, treatment, and rehabilitation across the 15 priority conditions that have been mentioned. And if you look at it more deeply, all of the NCDs and injury-related priority conditions would require surgical intervention at some point as a diagnosis, treatment, or for rehabilitation. And for about 75% of the infectious and maternal health priority conditions would also require surgical interventions. So And there is also strictly a module that is dedicated to surgery. So what we'll realize is that an in-depth analysis of the 19 intervention modules will show that effective implementation of surgical interventions is essential across a number of them. This comprehensive approach will allow for strengthening, ultimately, not just the entire health system, but surgical ecosystem as well. So we would say that the surgery module, like I said, exists and has been identified by a country as a module that they want to focus on. Budgets have been allocated. The broad intervention for the surgery module is to address common surgical conditions with a focus on injuries and digestive diseases. And candidate interventions, maybe like the ones I've listed here, like trauma and emergency surgery, emergency obstetric care, neonatal surgery, cancer surgery, and surgery for non-communicable diseases have also been identified, and outcomes, relevant outcome measures defined. Next would be to select the most cost-effective of these interventions, and if you look at the last column here, there is a breakdown of what more detailed intervention, more specific interventions can be under each of these broader interventions. So the next would be to select the most cost-effective of these interventions, and one can go further to maximize the cost-effectiveness of these interventions by mixing them within modules. For example, there is an intervention that says screening. That's screening for surgically correctable congenital anomalies. That can be put into the immunization module to improve the cost-effectiveness of implementing that particular intervention. Or if we look at emergency obstetric care here, which also is coming up in surgery, but that can also be put into the module on pregnancy and childbirth services. And this would help to improve the cost effectiveness of implementing these interventions. And if you want to apply this to sexual and reproductive health, a country where this is of relevance, of high importance, one can define a sexual and reproductive health module, define the key interventions that should be there within the context of that particular country to ensure that interventions are not fragmented across different health system areas, but considered holistically for impact and for resource allocation, right? And then one can now carry out the cost effectiveness of these interventions, while again, I mentioned at some point something that relates to social consideration, like equity considerations, right? Interventions that will benefit marginalized populations like adolescent girls may be prioritized for funding, and then ensuring that these services are covered by health insurance schemes holistically to prevent any form of catastrophic health expenditure when accessing that. And by applying this approach, one can ensure that sexual and reproductive health interventions will receive consistent funding, have a structured implementation, and can be integrated more effectively within the broader health system goals while optimizing impact. What are the implications of the modular approach for health system strengthening? And this will be my last slide. Basically, it helps to advance discourses around health system strengthening in 4 important ways. One, it shifts focus towards the 15 priority conditions. And Angela has talked extensively about how important it is for countries to focus on these conditions, and ultimately it will help to strengthen the health care system. It helps to maintain focus on a limited set of interventions that could inform drug formularies and procurement systems. This has also been talked about extensively. It could help to guide conversations around international conversations around workforce. I know workforce migration or redistribution around the world is a very topical issue at this particular point. So a particular country can use this modular approach to guide their workforce development plans, including training curriculums before service or during service, and align these with the priority conditions. And it can also help to provide a roadmap for health system development, by informing what sort of key indicators countries should routinely collect, digitize, such as expenditure data, service utilization data concerning the priority conditions. I think I'll just stop here. Thank you very much.
Thank you, Justina, so much for an excellent presentation. Very interesting indeed. And I would love to hear more. And I think we will have questions in the end. But I will hand over to Jesper as our third speaker so that we can take all the questions in the end. And Jesper Sundewall is a researcher at Lund University, a specialist on health system strengthening and health financing with a special focus on sub-Saharan Africa. And Jesper has been involved in the previous Commission on Investing in Health in 2013 and has now also co-authored the chapter on the Commission that was published in the EBA report last year. So please, Jesper, the floor is yours.
Thank you so much, Malin, and thanks to the previous presenters. So what I will try to do is to try to put the Commission findings, both last time around and this time around, in the context of Swedish development assistance for health. But first, I want to sort of make a little bit of commercial. If you haven't already, the anthology that Malin held up in the camera, it provides 17 perspectives on global health. Most of them are in Swedish, but I also note that most of the people on the call are Swedish speakers, so it shouldn't be a problem. So if you haven't already, please have a look at that. It ranges from migration and trade and pandemics and what have you, and not least then, of course, investing in health. And this is a snapshot of the chapters in the book. But for the purpose of today, so Malin, I mean, I wasn't in the Commission. I'm not a commissioner as such, but 10 years ago, I worked at the EBA. And one of the very first report that we produced is the one to the left, called Sweden's Development Assistance for Health, Policy Options to Support the Global Health 2035 Goals. And it was basically me, getting Dean Jameson that Angela mentioned on the phone and saying, you have a really interesting report out. Would you mind doing something on that with the Sweden as a case? And the team was really sort of inspired by that. So we ended up producing one of the first EBA reports ever where we looked at that. And then 10 years later, there was a new commission, but also a new EBA report on investing in health. So, the stars were aligned, and we thought it was a good opportunity to have another run at Angela, Gavin, and Justina, and all the other commissioners, at least summarizing the results, and myself coming in then maybe trying to follow up on some of the key things that were brought up in one of these, in our EBA report back in 2014. So that's what I'll do for the next 5-10 minutes. So if we revisit recommendations and conclusions, well, in the 2014 report, we sort of discussed the future trajectory of Swedish development assistance for health, and we modeled that, and I couldn't find a nice figure of our modeling and in high resolution, so I'll just talk about it. But basically, we said, we assumed continued growth of aid because at that time we had a 1% target of GNI for aid, so it will grow by the year. And then we said, what if we have a larger share of that aid going to health? What would it look like? And how much more money could we actually mobilize for health? But as Angela said, unfortunately, the golden decade of health aid is long gone, and we haven't really seen that growth of development assistance for health that we were modeling, not at all. If we look at how it went, and with Sweden as a case, this is what has happened over the last 15 years in terms of Swedish development assistance for health. In the bar charts, you see the amounts adjusted for inflation with 2010 as index here. And in the red chart at the top, you see the share. So we have gone from about, just about 12% of Swedish development assistance for health in total, Swedish development assistance going to health, to just over 10% in 2023, and with a likely reduction in 2024, I would say, even though we don't have the data yet. And in real numbers, we also see quite a clear declining trend, which is not strange because we no longer have growing resources for development assistance or development assistance for health, now that the current government has chosen to sort of leave the 1% target and more aiming for a 0.7% target. So we assume or expect, if we were projecting an increase before, I think we're more likely to project a decrease in aid going to health. So we haven't really they haven't really followed that recommendation. But let me say, how, I played with words, how big is Swedish development assistance, or how small is it, just to put it in the context. Well, development assistance is small to start with. This is, how much is Swedish development assistance as share of total Swedish healthcare expenditure, just to show, it's less than 1% of total healthcare expenditure in Sweden is actually, the amount of money that we actually spend on development assistance for health. So that puts in perspective, how much money we're talking about, even though we tend to say that it's one of the biggest priorities of the Swedish government. It's still a very, very small amount of money compared to how much we spend in Sweden on health. And if we look at development assistance more broadly, this is global health expenditure and different sources of global health expenditure. And if we take that small, green thing that you can hardly see at the top, that's basically development assistance for health. You can hardly see it. That's how little it is. So when people say, how much money do we give for health in the world, we can say, well, how little money do we give for health in the world? It's extremely limited, and it's, unfortunately, decreasing by the day. However, and there's always a however when you do these things. If you look at the low-income countries and the lower middle-income countries of the world, development assistance for health is still quite a significant share of health expenditure. Low-income countries to the left, we can see that about 40% of health expenditure in an average low-income country is from development assistance for health. As countries get richer, we take lower middle-income countries, that share rapidly decreases, both because they don't need it and also because, historically, priorities have been for development assistance for health to support, the poorest countries of the world. So in the poorest countries, it's still important. And if you recall, then one of the recommendations, both in the 2014 report and today, was, to focus direct country support, development assistance for health, to the most resource-constrained countries. So the low-income countries and maybe even the least income countries or the least developed countries. And if we say, have we done that in Sweden? Well, I think it remains to be seen. We see now, since 2022, and a new government and a decreased envelope for development assistance more broadly, that resources are going down. They're also trying to focus to fewer countries, right? But it's still a bit unclear exactly what those countries will be. And we have also seen that, some of the countries that previously received the development assistance for health, for example, Zambia, are no longer receiving that. And Zambia is one of those countries just bordering lower middle income countries. So maybe, that actually makes sense. But I think what we have seen and what is becoming very clear is that, we are not necessarily focusing bilateral support broadly on the most resource constrained countries, or the poorest countries at least, because one of the big priorities these days is Ukraine. And just the other week, maybe Justina and Angela don't know, but, we had another 1.5 billion, I think, reallocated to Ukraine, which means that 14% of development assistance in total in Sweden is now for Ukraine, which you can have different opinions about, perhaps. And I don't think nobody has, any other opinion that Sweden should support Ukraine. But it is, of course, a shift in what types of countries and what types of support Swedish development assistance is targeting. Another recommendation which we brought up in the 2014 EBA report was, to prepare for the next influenza pandemic and tackle antimicrobial resistance. These are these things, that they highlight in both these reports that, transcend national borders. They cannot really be handled by countries individually, and that's, there's a role for global financing, such as development assistance for health. And Sweden at the time, we were praised for being a country that really took sort of a leading role in especially tackling antimicrobial resistance. So, that was recognized. Continued to invest in AMR. This is the recommendation on the left, preparing for the next influenza pandemic. And just recently, we launched a new strategy for health and sexual and reproductive health and rights 2025 to 2029, or the government issued this strategy. And one of the explicit priorities in that, beyond, sexual and reproductive health, was on antimicrobial resistance. So we're staying the course, I think, continuing to highlight that as a profile issue for Sweden and as a priority issue for development assistance for health. So I give thumbs up and say we might have met that recommendation. Another recommendation or message coming out was that Sweden should continue to invest in global health leadership, global public goods, and support to multilateral organizations such as the WHO. And we've talked some of these global public goods. You can argue that, combating AMR and preparing for the next pandemic, but also developing new health technologies are among those global public goods. But what if we look at the multilateral organizations? Well, what we've seen so far, and it's changing by the day, Sweden is also reducing, generally, we say, there's less, more criticism, I would say, against the global health community or the multilateral system. UNAIDS is no longer there. We completely said goodbye to UNAIDS starting 2025. And we have reduced contributions to UNFPA and the World Health Organizations. However, more recently, as we say, a lot has happened even since you published this report, Justina and Angela, in terms of the world changing. And Sweden is sort of, revisiting this. And I know that we have sort of, now taken decisions to sort of take back some of that funding for UNFPA, and in particular funding for UNFPA in countries like Ukraine. So while it's going down, I would say overall, there's definitely an awareness in the Swedish government about, the implications of funding for the multilateral system in light of the US withdrawal from the WHO and defunding of UNFPA and other trends going on. So a bit of a mixed picture, I would say. But of course, given that we have an overall reducing aid envelope, and even though health is still a priority, it's being sort of, pushed by that overall reduction. We're seeing, cuts in many different aspects, of which I highlighted a few. So I will also stop there, and thank you for listening.
Thank you so much, Jesper. So that has been 3 very interesting presentations, and I think you have really complemented each other. I think actually that I will try to give our participants allow them to speak, because I think it will be better, because we don't have any questions in the chat. So we only have about 15 participants. So I would really like you to get the chance to reflect, even if you don't have questions. So please ask for the word to talk in the chat or in the Q&A, and I will, allow you to formulate your own questions. Okay, but in the meantime, maybe a question from me. I was really curious, maybe mostly to Angela and Justina, to start off with. What is the response that you have received so far in presenting this to policymakers, to multilaterals, and most of all, if you have experiences from responses in countries, like from national governments, ministries of health? What is the response to this?
Yes, maybe I can start, and then I'll hand over to Justina. So always sort of my feeling is that these kind of high-level reports are only useful if countries take it on themselves and customize it based on however their priorities. And so we've been quite lucky in working and getting some funding, also support, working with Nigeria. So Minister Pate, Mohamed Pate. We have been working with Nepal, Taiwan. We are doing something in the US as a US Commission, and potentially China. So we're sort of customizing based on what the countries are interested in, their priorities, and trying to work with countries. As I mentioned before, I think the 2 things that I think have caught attention one is the optimism of global health. And maybe now is like the terrible time to say it, right? Because it's the opposite.
I think it's perfect.
But at least a month ago, there was still we knew that funding was going down, right? We knew that overall funding, and we've also positioned health to be mostly a domestic or regional agenda. It should not be, as Jesper showed in the numbers, like it's not a global agenda, except for certain things, right? So most health should be country-led, region-led, and so we push that. And I think the optimism of that we were not expecting that it would be an optimistic report, but we ended up being so, despite all the challenges that face. I think that was quite appreciated by many. The arrow mechanism about drugs, I think really many of the ministries of health are concerned about out-of-pocket payments for drugs, even essential drugs like hypertensives and anti-cholesterols and so on. And they should be cheaper than they are right now, and using the arrow mechanism to do something about it. It's something that we're discussing. We also received some criticisms. The two things that come up quite often, one is around the fact that we don't really talk about malnutrition, whether it's overnutrition or undernutrition. Right now in Paris, there's a nutrition for growth or the summit happening in Paris that some of us are there as well. And that's something that we did not talk about. And I think it is a mistake that we made, partly because we do not have the expertise in that. Partly we have been, and this relates to my second criticism that we have received about, I think in global health research, we have taken a very medical approach. We talk about ICDs, we talk about cause of death. We don't really talk about, or rather the data structure is not there to talk about morbidity, well-being, functioning of people. And we recognize that. And it is, I think, as a whole, the field as a whole, including myself as a researcher, that is a big constraint that we have. We partly blame the data structure is not there for us to say anything, good, I think qualitatively high quality about it, but it's also our way of thinking that it's also, I think, a bit constrained in, risk factors. There are many other risk factors and climate change and all those things that are intertwined, and we are not equipped to tackle that. I'll stop there. Tina, maybe you have some things to add.
Yes.
Yeah, thank you very much. Yeah. So the report has been presented to several, just like Angela said, several organizations, right? And the reception has generally been very, very positive. I've been part of a number of the presentations, to the Bay Area Global Health Alliance in San Francisco, USAID, and World Bank, and PEPFAR. Very well received, across all of this quarter, Center for Global Development, and also to countries, Nigeria, my country. And like she mentioned, there's a Nigeria CIH coming up in the next couple of weeks, should be launched. And and even the arrow mechanism has already been approved by the Ministry of Health in Nigeria. Yes. So those are some of the things that have been ongoing. And like she said, again, there's been some negative reception, some very strong criticisms, which again, the Commission is very open to, and discussions have been ongoing. And of course, it's not perfect, like Angela said. When it's improvement, we'll definitely get improvements. The reality is, like she mentioned when she was presenting, people have lots of priorities, right? Sometimes I would say, as a clinician, some of these priorities, when I listen to them, they sound like individual specialty-oriented priorities. Why are you not talking about this particular disease condition, right? And what I try to say is, there are 15 priority conditions, gaps in life expectancy and gains in that very wonderful, amazing chart that was shown. And there is others. So the aim is not, again, to go pursuing everything, but to focus on the 15 priority conditions to achieve the impact that was suggested. And in some instance, focusing on that, some of the conversations that have gone on in some instance, focusing on mortality can also help to strengthen the system to tackle morbidity, even if not completely, but it can, and that is very critical and crucial in low and middle income countries where mortality is still a very big issue, but then again, we still need to give some focus to morbidity. But then even this, it still has the capacity to be very, very impactful. Thank you very much. I think I'll just stop there.
Thank you. Actually, I'm really curious to hear more about the critique, just because you mentioned it, that has come. But I think we have a question from Karin Berlin. Karin, would you like to ask your question yourself, please?
Yeah, sure. Thank you.
Interaction here.
Yeah, thank you. And no, excellent presentation and very interesting reports. I was just wondering to what extent the findings and the messages have been discussed and kind of endorsed by the WHO. I heard you gave examples of World Bank and PEPFAR, some countries as well. But how has this been on the more of our main architecture of global health at the WHO? Thank you, and over.
Thank you. Thank you for the question. And thank you raising it up. So before the WHO faced their financial crisis right now, we were, and before the report was published, we actually got Dr. Tedros attended like a 2-hour presentation from one of our commissioners and Dean Jameson as well. So we were very supported by Dr. Tedros about this. And I think my understanding is that they also wanted to use this as an opportunity to kind of refresh the future of global health and strategy. So we were very well supported. And then after the publication, and so Dr. Tedros was quite involved in this thinking about 50 by 50, this target, and whether WHO's next strategy should incorporate some of that 50 by 50 goal in their strategy as well. So that was a conversation we were having about measurements. And then since the publication, I think they were also quite interested in the arrow mechanism. Can the WHO provide some guidance on how countries can set up arrow mechanisms customizing based on different countries and disease burden and so on. So that was supposed to happen actually a month ago, where Dean Jameson and Dr. Richard Pito from Oxford, they were supposed to go brief Dr. Tedros, but then of course that got canceled because all the things that are happening with bigger priorities right now for WHO. Now, back to the criticism about morbidity and us not really focusing mostly on mortality. Right now, we are working with the non-communicable disease team at WHO to write a proposal to try to get some funding to convene an expert group talking about similar approaches that we have done so far with the Lancet Commission, but focusing on non-fatal outcomes. We're not there yet in terms of functioning and risk factors and so on. We're kind of gradually going down the chain of different health measures, but so we're trying to do something about non-fatal outcomes. And how do we think, how do we think horizontally across all types of non-fatal outcomes and think about how do you measure them, how do you value them, what are the interventions that are available? So systematic approach similar to what the Commission has been doing so far with mortality.
Thank you, Angela. Karin, was that a good response for you? Yes. So please feel free if you have questions, our audience, to pose your questions, because you are now allowed to speak if you turn on your microphone. But I had a question for Jesper in the meantime. So I know that you have also, in the anthology, you also wrote another chapter on bilateral aid from a Swedish perspective. And I was wondering, do you have any thoughts? How could this be more from a Swedish perspective? How could this approach with the 15 priority conditions and the modular approach and so on, is that something that could be integrated in Swedish bilateral health aid?
Thanks, Malin. For those of you who have not read it, that chapter was a bit of a criticism towards sort of, the bilateral aid model for health. And to some extent, saying, in some of the countries, especially where we have this sort of long-term development cooperation for health, we are supporting countries that to some extent probably should take a bigger responsibility for these things themselves. And I use the examples of Bangladesh and Zambia and also Uganda. But for sure, I think when I listen to the modular approach, it's very much when you're at the country level, you probably call it some sort of health benefits package process, right? Where you define interventions that are supposed to be universally available for the entire population. And I think and that's what countries are trying to do. And again, I'll take Zambia as an example. They expanded with a national health insurance. And putting together a health benefits package, which the population is supposed to be eligible to have. And one of the criticisms you could say is that that didn't really take a modular approach. I think it tried to be very expansive and comprehensive, and not really thinking doing it based on analysis on what could you afford, which I think is also an important dimension to think about here. But secondly, what are the biggest health needs that we're actually targeting on a universal scale. But then, you also need to recognize, I mean, Angela said, what happens at the country level is, where this should happen. And of course, you can sit here and do some, rational prioritization, but for a minister of health, there's more than this rational prioritization going on. It's politics as well. And they have, a share of the population which have much higher expectations, or expectations for other health needs to be met. And as a minister, you need to balance that. But I think, by making, and that's what we talked about, we talk about it in classes as well, by making priorities explicit, you also create conditions for accountability by saying, this is what should be prioritized. This is what are the biggest health needs and what are maybe the most cost-effective approach of doing it. It's easier also for the government to show the progress, but also for the people to hold the government to account for, how these priorities are being set. And when then you take the layer of development assistance for health, unfortunately, there's quite a bit of path dependency in development assistance. We're giving money to what we have given before. And, the US had a priority around HIV, and Sweden around SRHR, and somebody else around, vaccinations. And to try to get all that into this modular approach is not easy for a policymaker. So I also called for, if you want to provide direct country support, it needs to have a broad approach. And this modular approach could be such an approach, but you need flexibility and a broad scope of your assistance for it to have the potential to be effective when you're trying to support these types of interventions. That's what I still strongly think.
Thank you. Thank you so much. We soon have to wrap up this webinar, but we have a question. So I will read it because I can't see the name. That aid should go beyond provision of money. Does Sweden plan to continue to provide technical assistance to low and middle income countries to ensure sustainability in domestic health financing? Maybe Jesper, maybe you want to.
I mean, I don't know what Sweden exactly plans to do, but I mean, we argue for that, of course, as well. There are other ways to cooperate. In some of the chapters in the book, research is highlighted as one example where you can maybe contribute, to a stronger health sector without necessarily providing support for service delivery. Because I think providing support for service delivery, in my view, with aid is becoming more and more redundant in most countries, and fewer countries, actually need those resources, or aid can actually make a difference in terms of money for service provision. That said, there are many needs in terms of, developing the health system and the health sector in these countries where technical assistance can continue to be a vehicle. And I think definitely, Sweden should do that. And it's probably, better use of resources given, the marginal utility that aid can play in more and more countries. I don't know if Angela has or Justina have a differing view.
Yes, I think because we are running out of time, I would like to ask Angela and Justina if you want to have some words to say as we wrap up. Final words. Maybe.
Okay, I think I'll just go.
Yes,
I want
please,
to go first here. Yeah, sure.
What should we remember? Take with us.
Yeah, the 50 by 50 agenda is an optimistic message, and like has been clearly outlined, is achievable. And I think everyone here should be an advocate for countries to actually try to focus and to spread the message on how premature mortality can be halved by 2050. And just a little take on what Jesper was talking about before. I'll try to make it very brief. I love the chart he showed about what percentage of the global health spending is DAH and how much those countries are actually spending on health in total and what that means. What I would want to say is that I think countries should be encouraged to take responsibility, because if DAH is taking that much of the percentage of what you're spending in your country, yes, you're low resource LMIC. I'm from Nigeria, so it's LMIC. But the question is, are you giving enough to health, even as a country, from all of what you have? Are you giving enough to health as a country? Because clearly reliance on aid is an infographic I got yesterday. So many countries, more than 10, that were giving to aid to health before as aid are cutting. And we can't continue to rely on that. So just like has been said, technical assistance, how can these countries be empowered to give more of their own local resources to health? And that is what is most sustainable in-country financing, not reliance on aid. Take responsibility. Thank you very much. I think I'll just stop there.
Very, very good take-home message. And Angela, you will have the final words.
Thank you. First, thank you everyone for staying till the end. One thing I would try to remind everyone is to think about long terms. I think we often look at what's immediately available, what's happening. So geopolitical tension that's happening immediately, the funding cuts and so on. And we tend to forget the bigger, longer picture of things. For example, R&D, pandemic preparedness, things that we don't see, but that's going to happen. And for example, the benefits that we are getting now in many of the diseases have been this R&D investments from Sweden, from Denmark, from the US and other places from decades ago. And I think that's really important to have it's not about the immediate things but it's the difficult thing to remind politicians that long-term aspect is important.
Thank you so much. And really a big thank you to all our presenters and to our participants. Thank you for joining this event. And I hope that everybody has really learned something new about the Lancet Commission. So thank you to all of you. And thank you for staying with us until the end. So hope to see you in our next event on global health.
Thanks so much.
Thank you, everyone.
Thank you.